So again, we're going to aggressively rotate that finger that 360 degrees. Now, in addition to being very uncomfortable for the patient, speaking from experience, it's the purpose of it is to cause uterine irritability, which I would be irritated. I mean, I felt it. And possible labor within 24 to 48 hours. Now, for me, it did not work. Elijah was not going to come out for anything. Non-pharmacologic methods. So these are methods that people use, old wives' tales. There are some that have some studies that have been published that say one way or the other as to whether they actually help. Sexual intercourse, there's no evidence. Nipple stimulation, there's no evidence. Ambulation, there's really no evidence. Okay, but these are things that people do. They're trying to irritate that uterus, for one, with ambulation, and then sexual intercourse and nipple stimulation, they're trying to release that natural oxytocin, right? So, you get a partner and you go to town and you hope it works. Blue cohosh and castor oil, these two things together can have some labor stimulation effects. Black cohosh and evening primrose oil can also help to ripen the cervix. Some folks also use acupuncture as a method of way to kind of stimulate uterine irritability and to help in the release of prostaglandins. So remember when we were talking about engagement and how we really need to make sure that head is engaged before we rupture those membranes. Well, this is how we artificially rupture those membranes, or an amniotomy. So we need to have that baby engaged at that 0 station. This will shorten labor by about 2 hours. The one benefit of an amniotomy versus a spontaneous rupture of membranes is we get a first-hand look when we rupture those membranes as to the color and if there's any odor. So this is the huge potential risk that I just keep talking about in regards to induction and augmentation, and that's the prolapsed umbilical cord, and this is an obstetrical emergency. So in this case, the umbilical cord is either shortened and it's between the head and the cervix, or it's actually dangling outside of the cervix. In either case, what's going to happen if this is not caught in time is the head is going to compress against the umbilical cord during the laboring process, which will then cut off blood supply, oxygen, all of those vital things that the baby needs during labor. So what we do in this position is, if we happen to notice that there's a prolapsed umbilical cord, this mother immediately goes into a knees to chest position, like a downward dog kind of yoga position, and what we're doing here is we're trying to get the pressure off of that cervix. We're trying to, without forcibly pushing that baby back in, we're going to place our hand between the baby and the umbilical cord and keep the fetus from putting pressure on that umbilical cord. The nurse in this case is usually going to be on the gurney or on the bed. If they come in through the emergency room and this is detected, again, obviously we're going to try to use sterile gloves because high risk of infection, but you gotta do what you gotta do. Sheet is over mom and nurse is riding the gurney with mom to the OR. Okay, we're going to stop Pitocin. We don't want any additional measures that are trying to force that baby out using those involuntary powers. We're going to turn on oxygen at a full 10 liters and a stat section. So oxytocin, or Pitocin, this is the augmentation method that you are going to be most familiar with. So again, oxytocin in its natural form is a hormone that is produced by the posterior pituitary gland. It stimulates uterine contraction and it aids in milk letdown during breastfeeding. So Pitocin, or PIT, as you'll often hear it called, is used to induce labor, and it also is used to augment or help to progress labor, especially with those hypotonic uterine contractions. Pitocin is usually piggybacked into the primary infusing line, which is usually LR. The dose is titrated until the woman is contracting. When we have PIT running, we do need to be watching that mom. All right, we have potential complications, and I would recommend you read over that in your text around page 704, where it talks about uterine tachysystole. There's a box. So this is talking about more than 5 contractions in 10 minutes averaged over a 30-minute window, or a single series of contractions lasting greater than 2 minutes, or contractions of normal duration occurring within a minute of each other. What is happening here? We're not being able to perfuse appropriately. So when the uterus maintains, and when the fundus is maintained in that contracted state, what else is contracted? Like, think about is the placenta receiving perfusion? No. If the placenta is not being perfused, is the baby being perfused? No, it is not. So it can lead to it can lead to a fetal demise, which obviously we don't want that. We want healthy mom, healthy baby. So if we aren't able to relax our uterus, then we need to intervene in one way or another. That is a potential complication of the use of augmentated or Pitocin. Perfusion, perfusion, perfusion. I don't think that I can state that enough.